You know, I joined the group almost a year and a half ago. We lost Dr. Nikravan, but we are hiring 2 more, so hopefully the department will get more support and help. So this is a talk about, I would just say, an update in diabetes, sort of how we approach diabetes from an endocrine point of view and share the experience with the general practitioners and family physicians as well. So this came actually initiated at the St. Joe group. The endocrinologist kind of wanted to get everybody on board in terms of managing diabetes. And I kind of blended a few additional things into the talk so it's not that boring. So the definition of diabetes, there are 2 words, diabetes and mellitus. Diabetes means to go or run through and passing urine. So mellitus is a honey sweet thing. So passing a honey sweet urine, that's the origins of the definition of diabetes. So probably none of us is doing this lately, but there are other methods we use. So this is where my old country is, Turkey and Cappadocia region. I'm just going to expand the map. That's how the world looked back then in early 2,000 years ago, or beginning of the Christianity and all that time. And that's the region where the diabetes was first described by a physician called Arrhetius. So these are very interesting structures, like cave-like, and not man-made, it's just all natural. You know, earthquakes and you know, winds and all that have shaped these structures. And there are underground cities in that region. So it's many layers of, they lived here for centuries. These are the early Christians running away from the Roman persecution. So this is the Dr. Den who first described the modern, in a way, modern diabetes. So, and he lived in Cappadocia then. So I guess they thought it's a problem of a kidney at the time, back then. So bringing us to today, talking about the prevalence of diabetes, it's huge. This is a little bit of an old slide, 3-4 years ago, and now there's a paper just came out in Annals of Internal Medicine that the percentage of diabetes incidence is about 10%. This is about 8% here, and over the years, you see that the numbers are on the climb. And this is really proportional with obesity. The top 3 maps are the obesity map, so to speak, in the United States, and then the bottom 3 are the diabetes. Very similar. So the burden of diabetes is really huge. It's the leading cause of near blindness among adults, kidney failure and dialysis, non-traumatic lower limb amputations, and then neuropathy. About 60 to 70% of people with diabetes will have some form of nerve symptom or injury or complications with nerves. And then it increases the risk of heart attack and stroke by 2-fold, and 7th leading cause of death, and mortality rates are 2 to 4 times higher if you compare a diabetic to a non-diabetic individual. And the financial burden is also very huge. Almost $250 billion a year is spent on diabetes. And if you add other diabetes-related conditions such as prediabetes, unrecognized diabetes, gestational diabetes, the cost is much higher. And then 1 in every 5 healthcare dollars is spent caring for someone with diabetes. And 1 in every 10 healthcare dollars is directly spent caring for someone with diabetes. So this is what I just initially mentioned about coming up sort of some guidelines or protocols that will help us to manage diabetes better. And they're certainly not strict guidelines, it's just sort of recommendations. And then these recommendations were driven from the American Association of College of Endocrinologists, American Diabetes Association, industry experience, and then we kind of blended all that into some form of a guideline. So I'm not sure if this is going to ever happen, but they said we'll measure these benchmarks and try to keep the A1C level less than 8% and control the cholesterol well and keep the LDL less than 80. So this was sort of the group that we participated. From our group I participated, the others are usually, most of them were from St. Joe group, and Dr. Pereira was from Mission Rehab. So we met and came up with some guidelines. So these are the clinical indicators and suggested targets. When you treat someone with diabetes, what are the things that we are trying to accomplish? Try to accomplish the fasting glucose to be less than 130, even less than 120, A1C to be less than 7%, LDL cholesterol less than 100, non-HDL cholesterol less than 130, triglycerides less than 150, HDL if you're a man over 40, females over 50, and the blood pressure perhaps less than 130 over 80, which is maybe a bit higher based on the latest JNC recommendations.
Do you have a postprandial goal?
Postprandial goal, if you look at the American Diabetes Association's recommendations, is less than 180. However, I would like to see it at least less than 160 range. The 180 seems to be a bit high, and overall A1C reaches around 7% or so, so we try to keep it less than 160.
Are you adjusting any of those for age?
Yeah, that's a good question. Yeah, the latest papers, if you are really elderly and have many other comorbid issues, cardiac disease, stroke, etc., perhaps you should target less than 8%
Less than
age.
8, thank you.
Yeah. So this is a slide that kind of talks about the pathophysiology of diabetes. It's ominous octet. All these organs and tissues kind of works against the diabetic patient. So what I'll try to go one by one and what happens in different organs and tissues. The key organ will be the pancreatic beta cell, which we have the insulin production. So what happens in hyperglycemia, diabetes, is that we do have a beta cell failure. If someone is diagnosed diabetes today, it's demonstrated that 80% of the beta cell reserve is gone. So we are left with maybe 20 or 30% of beta cell mass to work with. And that's why you see over the years patients require more and more medications and failure and needing insulin. And that is one major defect, and the other one is insulin resistance, of course. So it's like two together, chicken and or egg. The insulin resistance happens in most of the tissues, particularly the liver, muscle, and fat cell. And as a result of insulin resistance, there is compensatory excessive production of insulin. And you might actually see high insulin levels in patients with diabetes, but it's just not enough to control the hyperglycemia. So in liver, we see more glucose production. If we are producing 2 milligrams of glucose per kg per minute, a diabetic patient will be producing 2.5. So it's about 20 to 30 grams of excessive glucose is produced in the liver. And that's why most of the time you see fasting hyperglycemia. Patient will say, well, I didn't get anything last night. What happened to my blood sugar in the morning? That's why, because there's excessive glucose production. And at the same time, we see increased lipolysis from the fat cell. So it's kind of an overflow. Fat cell can no longer accommodate fat and kind of flows over, and those free fatty acids are circulating in higher quantities and affecting all these organs, particularly the pancreas. The free fatty acids and fat, or in general fat, cause something called lipotoxicity, lipid toxicity on the pancreatic beta cell. Same thing happens when the blood sugars are high. If the blood sugar goes even over 120 or 30, we see that there's some impact on the beta cell insulin production. So you see a patient coming 200-300 of blood glucose levels, you start oral medications, it might not work because of this mechanism. Oftentimes you need to use some insulin to bring the glucose levels down and let the pancreas to kind of reboot again. So the same thing happens with the lipids. The same negative impact occurs on the beta cell. And same insulin resistance or adverse glucose production or diminished glucose uptake occurs in the muscle cell. That's why we tell our patients exercise, so that the muscles will suck up more glucose and help the hyperglycemia. And kidney. Diabetic kidney doesn't think straight. We are supposed to dump the glucose if we are having high glucose in our system. But diabetic kidney actually reabsorbs the glucose in an excessive way. So that's why they have come up with this new drug, the SGLT2 inhibitor, to kind of fool that mechanism and have the kidney dump the glucose. And the other very important system is the incretin system. The GLP-1 and GIP molecules are very important in the pathophysiology of diabetes. Relatively recent, maybe 10 years or so, we started using these medications, which I'm going to go one by one. But what happens is this molecule, GLP-1, glucagon-like peptide 1, is diminished in patients with diabetes. It is produced in the distal intestinal tract, and GIP, gastric inhibitory polypeptide, is produced enough, but there's resistance to it, and that's more produced in the proximal intestines. So the drugs that we use, the DPP-4 inhibitors, GLP-1 receptor agonists, raise the GLP-1 level, which helps in many ways. It helps to block the appetite in the central nervous system. There are the GLP-1 receptors. It helps the suppression of glucose production from the liver. It slows down the gastric transit time, because patients with diabetes, they don't feel full quickly because they really digest the food quickly. So in a way that inhibits that mechanism. So this is something that I worked on as a fellow, insulin signaling. The slide is showing us how insulin comes and binds the insulin receptor and then starts the cascade of events. There are two pathways. When insulin comes and binds the receptor called the IRS1, or insulin receptor, it phosphorylates and then lets the IRS1 kind of come and dock here and initiate this cascaded events, PI3 kinase pathway. And at the same time, it also induces the MEP kinase pathway. So here's the metabolic pathway, here's the mitogenic pathway. And when this system is activated, both pathways are activated. But there's resistance here at this level. So the pathway works this way. And that's where we see this proliferation and atherogenic effects of diabetes. That's one of the major mechanisms why diabetes has to do with cardiac disease, and cerebrovascular disease, etc. And this metabolic pathway is usually impaired. So now bringing to the medications that we use in diabetes, how they work. This is the first line treatment, most of the time, metformin or metformin ER. Decreases hepatic gluconeogenesis. That mechanism that we discussed before, it blocks the glucose production from the liver. But most importantly, we also learned that it also increases the GLP-1 levels. So it has those properties. And a few other things like blocking the intestinal glucose absorption to some extent. So as a result, it really helps the diabetic patient tremendously. It reduces the insulin resistance. It's considered a weight-neutral drug, so you won't gain weight on it or lose weight on it. But we see some weight loss most of the time initially when we start. But then when the appetite gets back, weight gain occurs again. So kind of neutral. And we try to use the metformin ER for less GI side effects. There are other preparations like Lumetza. They're very expensive. I haven't been able to have anybody covered with it, but the regular metformin with plain extended release works much better. Particularly if you divide the dose like 1,000 milligrams twice a day, and we initially start and titrate it up. I usually do it every week I add 500 milligrams. I don't need to go up on that quickly, so it's tolerated. And we try to not to use it in patients with renal impairment. So what is the cutoff? Probably less than 45. Definitely don't use it if someone has a GFR of less than 30 because of the risk of lactic acidosis. I heard, I haven't seen it since I heard, but a new metformin has been developed called NewMet. When you take it, it's not absorbed into the plasma, so plasma exposure is that low. You need that intestinal exposure, perhaps because of the GLP-1 effect. So we might be able to use that if it becomes available in patients with impaired renal function.
So I have a lot of diabetics that the GFR is in the 50s.
Yeah.
I feel comfortable using it if it's 57, 58,
Right.
56, something
Yeah,
like
very
that.
good. Yeah, very good question. Yes, I do actually.
If they
If
get
someone's
that-
really elderly and if I'm going to pick one as a first drug, then I probably wouldn't use it. But if someone is tolerating okay, they've been on it, and you monitor them long enough that CO2 is normal and no evidence of lactic acidosis and relatively stable renal function, I would use it, yeah.
Even in the mid-40s, down to 45.
I usually, myself, there's no maybe a lot of science behind it, but use 45 as a cutoff. Yeah.
Quick question.
Yeah.
If they went into a hospital for dehydration or something for acute event, I see them coming out without the medicine. If they stabilize back to their baseline renal function, I should be able to maintain them back
Sure.
on that.
Yeah, you
But I
can
see a lot of people just discontinue.
discontinue, never go back on it. Yeah,
or,
no.
or discontinued coming out and then telling them not to ever use it again. And
Right, yeah. What determines you look at the renal function. If you have a decent renal function, you resume. Yeah, exactly.
okay.
So the sulfonylureas is the second commonest group that we have been using for diabetic patients. So the glyburide, the glimepiride, the glipizide, those are the most common ones. Obviously, we all know that they have their receptors, sulfonylurea receptors in the pancreatic beta cells that you go and detach and let the insulin being secreted. So the risk is hypoglycemia and weight gain, and some concerns about cardiovascular, mortality. It's a bit unclear area, but we use it commonly. I think it still has a role. The problem is after some time they don't work so well. So a year and a half to 2 years, they might work okay, and then you see the blood sugars are rising again. So most of the time, 50% of the dose is usually enough by going a glimepiride, say from 2 milligrams to 4, maybe a little bit of benefit, but then you won't see much if you maximize it. The same thing with glipizide. The renal function is also important when we are using the sulfonylureas. The glyburide, we hardly ever use it now. One of the reasons is that metabolites are also active. When it's metabolized, it can cause hypoglycemia. The plain glipizide and glimepiride, they are a bit safer because their metabolites are not active. And obviously, patient with renal impairment, you want to be extra cautious because of the hypoglycemia risk. So we commonly see patients, particularly elderly, they get dehydrated, something happens, an event happens, and sulfonylurea is on board, and you see the blood sugars in the 20s and 30s, and it takes days to recover from hypoglycemia from a sulfonylurea. If it's instant hypoglycemia, it's quick, short-lived, but this can be a really big problem. We have kept patients on D10, D20 drip for days to improve the hypoglycemia. So the other class is the TZD class. Now the only one that lately we have available is the Actos, and Evendy is coming back after all that cardiovascular issues and stuff. So problem, well, they're actually good medications. They really work well. They're very strong. It's a good add-on to metformin. Hypoglycemia risk is not there, but there's some weight gain. They always say it's a good weight gain. The fat is redistributed to from the abdominal areas to subcutaneous areas, so it's not a metabolically bad change. So you don't want to use it in a patient with a congestive heart failure because of the fluid retention risk. So there's some data that it can cause osteoporosis. And cardiac mortality, I don't think it has ever been clearly proven that they have any adverse cardiac effects. Probably it's beneficial because it does cause changes in the vasculature, positive changes, and also risk of bladder cancer. So it is probably to some extent elevated, but not that high. FDA hasn't given us clear, guidance on that. So what is known so far is if you use a high dose long periods of time, then maybe you're risking the bladder cancer risk a little bit. Definitely don't use on someone who already has bladder cancer or a history of bladder cancer. I always think about it. And I don't think there's any way to monitor that. You can make yourself better, you can check a UA or microscopic hematuria, but it's not in the guidelines.
Would that be a factor in smokers?
Smoking, yes. I'll be more cautious. I don't know if they've done any studies on it, but I'll be more cautious on a smoker. Definitely, I wouldn't probably pick as a choice because they both two high risk issues. So you probably don't want to use it in someone who's already smoking. And the other thing is that this is probably the only medicine that preserves beta cell function. So it does take that fat out of that beta cell. So it's in that sense, if you use it, it can have the pancreas last longer. So this is the group that we talked about, GLP-1 receptor agonists, the Byetta, the Bydureon, the Victoza. Byetta is a twice daily, Bydureon is once weekly. And now a pen is also approved for Bydureon. So it's a little complex with a vial and syringe, with a large needle. But now, I haven't seen the pen yet, but I know it's approved once a week. And then the Victoza is a daily injection. So they, Byetta was developed because Exendin 4 is a lizard, from the lizard saliva. It has about 60 to 70% analogy, identical with the human GLP-1. Victoza is almost 95-98%, I think. So it's more close to our GLP-1. But the effect is the same pretty much. What they do is they help the pancreas to produce better amount of insulin, but in a glucose-dependent manner. If you're hypoglycemic or low glucose, they won't stimulate the pancreas. That's why we don't see hypoglycemia. And if, of course, if it's combined with insulin and sulfonylurea, yes, but by themselves, combined with metformin or lactose, we won't typically see. And then they also reduces the glucagon secretion. Glucagon is a bad hormone for the diabetic. Glucagon levels are typically elevated. And when they block the glucagon receptors, they have seen improvement in glucose levels. We don't have a drug for that, but as a physiology, we know that. And also, the GLP-1 analogs, as I mentioned initially, reduces the appetite and reduces the hepatic glucose output. So it affects multiple areas, and as a result, we see up to 2% A1C reduction. With the Bydureon, it doesn't work right away, so you just have to wait several weeks for it to kind of kick in to have a stabilized effect. So they cause weight loss. That's a great thing. They slow the gastric emptying. Initially, you will see this nausea, so you start at low dose and titrate it up. If needed, you can use antiemetics to help the patient get through that first few weeks of period. And pancreatitis issue or pancreatic cancer, not been proven. It appears to be pretty safe. If someone has pancreatitis history, I will use it. If someone has very high triglycerides, who is at high risk or very uncontrolled diabetic, who we know that they won't be compliant with therapy, probably those are the patients that I wouldn't use it. But most of the time, it's considered safe. Renal impairment with the Byetta, there's some restriction, so you don't want to use on somebody with a GFR less than 30. Victoza used with caution is not set number, so you can use it in most of the patients with renal insufficiency.
So could you comment on pancreatic cancer risk? Because I've had people refuse it for that reason.
I don't think there's anybody who has been proven to have pancreatic cancer to this date from any of these drugs. So there's talk about it. They have seen in some molecular studies, they do hyperplasia of the pancreatic duct cells, etc. But no cancer association has been proven so far.
Are diabetics in general at higher risk of pancreatic cancer?
That is true. They are also at high risk for pancreatitis.
Okay.
The pancreatitis risk is probably 2 to 4 folds higher than the general population. So is it the drug did it or because they were going to get it anyways? It might be, diabetes might be the very first sign for pancreatic cancer too. But we don't obviously screen everyone with pancreatic cancer coming in the first time diagnosed with diabetes. So the cousin medications are the DPP-4 inhibitors. They inhibit the enzyme, and as a result, they also increase the GLP-1. The Januvia, Angulosa, Teragenda, and Sina. So basically, they help the GLP to go high. GLP elevation is about 2-fold with the DPP-4 inhibitor, and GLP-1 elevation is about 8-fold in a GLP-1 agonist. That's why they're more potent. And these drugs are also considered weight neutral, although you might initially see some modest weight loss. URI, UTIs have been reported. I don't see that much, but it's been reported. Renal impairment, you adjust the dose of Januvia based on the renal function. Angulosa, same thing. Teragenta, you don't need a dose adjustment. It's more hepatic clear. And they reduce A1C by 1%, in some studies even less, depending on the patient. And then the new group is this SGLT2 inhibitor, sodium glucose transporter. That's in the, I think it's in the proximal tubule. And this enzyme is blocked by this medicine. As a result, you see glucosuria, and as a result, the blood sugars come down and weight loss occurs. So it's a neat mechanism. So far, we haven't heard anything bad, but it's not been around that long. But there's some concerns about genital infections, myocardial or urinary tract infection, particularly in female, particularly in elderly female. I wouldn't probably use it if I have other choices. And renal impairment is also important to monitor because it can cause dehydration, can worsen the renal insufficiency. But it is something that is coming up. It's very expensive. Again, I prescribed a few patients. I wasn't able to. I was able to give a sample, but I wasn't able to get the accrual for it. So again, first things first, lifestyle modifications at initial diagnosis and throughout, referral to diabetes education. We have a very nice center, a health education department. They sit down with the patients in a new onset, or even someone who we think needs an update on their diabetes information. Please send them over. They'll sit down with them and go over most of the aspects of diabetes. They will make a referral to the nutritionist. So you can utilize a little bit more if you have a patient that you think needs help. So you look at the overall control, GFR, A1C, weight, comorbidities, physical exam. So every 2 to 3 months evaluate to see how the treatment is going. So, okay, so I'm going to just quickly go over this again. If someone has a normal or near normal A1C, mildly elevated A1C, first line, metformin, you can add a GLP-1 after that, or add a basal insulin as a choice. Someone has, let's say you see someone in their 70s, they have a GFR of 50 on metformin, and then you can maybe add a GLP-1 or DPP-4 inhibitor. They are expensive, so cost is always an issue. Or basal insulin, usually hypoglycemia is not that high if you're adding Lantus or Levemir or MPH insulin with metformin, which I'm going to email and all this, and then you can distribute that. Not earlier, but so the second group is a bit worse control, A1C 7.6 to 9%. Again, metformin and GLP-1 combination, perhaps. Add an insulin. The GFR goes down, so you be careful with the GLP-1 agonist and think of insulin. End-stage renal disease. Again, Trajenta might be a good option. And that's sometimes challenging with renal patients. The choices of medications are limited. Hypoglycemia risk is high. Oftentimes, though, when the renal function gets worse, it becomes a bit easier to control the diabetes because insulin clearance is diminished, and kidney also tremendously makes a lot of glucose, gluconeogenesis, so that is also gone. In some studies, as much as liver. So it's that's why most of the renal impaired patients find that their diabetes control is better. So A1C over 9%. Similar recommendations. Yeah. So this is something that I want to mention. We do have a protocol, which I'm going to email that as well, at our health education department, and they actually work with the patient. They call and they start, and based on your order, they will titrate the basal insulin on the phone. So you can utilize that. And here, okay. Yeah, so you can you don't want to titrate too fast. Perhaps every every 3-4 days or every week you can stop on the night dose, and then try to target the fasting glucose to less than 120 or so. Then you stay at that level. So the basal bolus is the pre-meal insulin. We tried everything. Most of the time, pancreas is already burned out. You don't get much of a response. Then you add meal insulin. It doesn't have to be 3 times a day. I have seen patients, I'm sure you do as well, having only elevations at dinner time or much higher at breakfast. So you just add to those meals, or just twice a day. Make life easy. Just skip the lunch and see if that works. And thank you for your kind attention.
Thank you.
I have a quick question. One of the problems, hopefully we run into less, but has been an issue, is trying to figure out a way to give only generics in treating patients. I mean, I remember, when MSI was in existence, that was a huge deal.
Yes.
Like, how do you treat only with generics? And I would think that there's still a lot of patients that are really kind of hesitant about brand name copays. So do you have suggestions in those cases?
Obviously, most of the patients that will be on metformin, hopefully, and then the worst is they can't tolerate, and you have not much choice other than treating them with insulin. I've seen drug reps coming in, they're giving out coupons. They sometimes work, sometimes they don't work.
Right.
Where I was before, the practice I was practicing in New York, we had no drug reps, no coupons, nothing, and we tried to do the as generic as possible. It's challenging. I don't have a good answer. If you think that they need treatment, but most of the time you pick up an insulin that is really not expensive, and then use that with metformin combination, or a basal MPH, for instance, or twice a day MPH, or our insulin, some of the meals,
Okay.
combined with metformin or a sulfonylurea.
So you would probably already work through TZD, sulfonylurea, and metformin.
Yeah, if you have tried all that, obviously you don't want to stop them, you just add the insulin on top. And be careful with the actose and insulin, the TZD, because more weight gain,
Fluid retention.
fluid retention, it's like that.
At what level do you start splitting basal insulin?
Like twice a day. Majority of the time, it's not needed. For instance, Lantus is a true 24-hour. Levemir the longevity is not that good. In a higher dose, perhaps it lasts 24 hours. So Levemir, you can probably split even from the get-go. The Lantus, you maximize, perhaps using 70, 80 units at bedtime, and you're still not seeing much of a response at that time. You maybe add another Lantus injection in the morning. And that brings me to the question, if someone who's really insulin resistant and they're requiring 200, 300 units a day, there's this insulin called insulin U500, 5 times more potent, more concentrated. Sometimes we use that. It's like an interesting insulin. It works like a fast-acting insulin, but at the same time it's a long-acting insulin. So you can dose it twice a day. There's no pen for it though. You have to pull. And then the dosage has to be carefully explained to the patient, because you don't want to give a 5 times higher dose. So 20 units of U500 will be 100 units of the regular insulin. So that sometimes I use. So I have all the time, and I prescribe. I always get a phone call from the pharmacy. Are you sure? Yeah, in the hospital, hardly ever in the hospital, unless someone is on it, and you kind of continue. Even that's a problem in the hospital. But in an outpatient setting, you can use it actually. I have seen good responses, and then the hypoglycemia risk is real with the U500. You've got to be very careful.
You have a slide that said that if they're on insulin, you try to minimize as many oral medications. But with weight gain and more insulin and more insulin and more insulin, I've seen that before.
Yeah.
So I've tried to maximize
And
some of my oral so that the insulin, I don't have to keep titrating.
That's what they said. I didn't mention that because I know it usually doesn't work that way from your practice as well. I mean, your experience. So if you can try, I had a patient just recently, a mentally impaired woman, very obese, and she had fluid retention, and I knew she wasn't, gaining weight, and she was on insulin and Actos, so I took away the Actos. A1C just went from 6% to 9%. So it happens. So you gotta maybe lower the dose, modify it that way, kind of play with it.
Any other questions?